Good evening, everyone. Thank you so much for coming. I'm Andrea Mantakunas, the Public Affairs Specialist here at the Gerald R. Ford Presidential Library and Museum, and it is my pleasure to welcome you tonight. Before we begin, I'd like to ask you all to please make sure that your cell phones are either turned off or on silent, please. We have some upcoming programs to remind you of. Our partnership with the World Affairs Council and their Great Decision Series has one more Tuesday night event. So please come back, join us next week for the final presentation in the series. And on March 28th, we will be partnering with the Barack Obama Presidential Library to bring you Dr. David Pilgrim, who will be discussing his work at the Jim Crow Museum of Racist Imagery. Thank you, as always, for your continued support of the library and the museum, and thanks to our great partners at the Gerald R. Ford Presidential Foundation. And now let me turn it over to Gleaves Whitney, the Executive Director, to introduce our guest tonight.
I think there was a little echo there, so I'm going to use my classroom voice. Can everybody hear me? Yes. Okay, just very short introduction. I just want to greet all of you. Thank you so much for being part of the program. One of the wonderful things about the partnership we've had with the World Affairs Council is noticing each Tuesday evening as more and more young people are coming in here. I think tonight's crowd has lowered the average age of our audience by about 3 decades. I'm really happy about that. No, we love all of you in here because it's so important to be familiar with the topics. You know, America has so many responsibilities. Brian is telling me I need a microphone.
They're videoing it so that people online can hear you.
Okay, people online, I'm welcoming everybody. So I want to say that it's so important that America, especially this is an election year, and this is the Ford. What is the role of the Ford in an election year? The role of the Ford in an election year is to remind people of the awesome responsibilities and opportunities of citizenship in a great democracy. So you've come to the right place. President and Mrs. Ford would be delighted. It was, after all, 50 years ago that he became president. She became First Lady of this great country. And we're so pleased with the partnership that we've forged with the World Affairs Council. More to come. Please welcome Michael to come on up, and Michael Van Denen is going to tell us more.
Thanks a lot. Thank you, Gleaves. Welcome to the 7th in our 8-part series. I cannot believe we're at the 7th of 8 already. Thank you so much for coming. And those of you who are watching remotely and here in person, we're glad that you want to be more world aware. Michael Van Denen, I'm the Executive Director of the World Affairs Council, and on behalf of my colleagues Erica Kubik and Rachel Brooks, thank you so much for being here. We do appreciate it. Thank you to the Ford Foundation, to Gleaves and his team, to the Ford Museum. We are so grateful to be in this place, and it's been just a wonderful run, and we hope we can do this again, maybe next year, possibly. I would clap for that. The mission of the World Affairs Council of Western Michigan is to empower the people and organizations of West Michigan to engage thoughtfully with the world. We do that with the help of our corporate sponsors right here in Grand Rapids, our educational institutions, many civic partners, and all of you. And we want West Michigan to be known as a globally friendly community. Thanks too for Wolverine Worldwide for being a great and long-standing partner of this series. We're grateful to them. The WGVU Public Media is our media sponsor. The Community Media Center in Grand Rapids is our communications partner. And on this particular program, we've got 2 very good friends. Corewell Health is a topic sponsor. Of course, they're interested in global health issues. And Grand Rapids Community College. And Dr. DeVivo, thank you to you and your team for just being great partners. In fact, it is GRCC that's taught us how important geography is to understanding the world. It's kind of a lost art. We were talking about that before the program started. And we're so glad that during the series now with the Great Decisions, we always seek out a geographer. And boy, do we have one for you today. We're grateful for that. Of course, after the presentation, there's going to be Q&A. We'll have the microphones around. You know the house rules. A respectful question and a succinct question. And now it's my delight to have the Vice President and Department Chief for Women's Health at Corewell Health, Dr. Cheryl Wolf, up here to introduce our speaker. Let's welcome her.
All right, good evening, everyone, and thank you, Michael. Corewell Health is really pleased to be a partner with the World Affairs Council of Western Michigan for this Great Decision series on global issues. As the last few years have demonstrated, global issues have significant implications for our health and well-being. What happens out there directly impacts what happens here, and the impacts are often profound and deeply personal. Tonight, we welcome Dr. Debarchana Ghosh, Associate Professor of Geography from the University of Connecticut, and I can tell you she's going to be fantastic. Following the completion of research devoted to a geospatial analysis of the West Nile virus, Dr. Ghosh was awarded the PhD in Geography from the University of Minnesota. Since then, she has explored a variety of issues relating to health and medical geography, such as neighborhood characteristics associated with cancer among African American men, food insecurity and chronic disease, impacts of structural racism on health disparities and geographic accessibility to HIV or AIDS healthcare services. Dr. Ghosh is a faculty affiliate at Yale University School of Medicine Center for Interdisciplinary Research on AIDS. She's also an elected national counsel for the American Association of Geographers, and she's a distinguished visiting geographical scientist. Dr. Ghosh's lecture, A Geographical Perspective of Global to Local Health Disparities, is sponsored by Corewell Health, Grand Rapids Community College, the American Association of Geographers, and the International Geographical Honor Society. Let's extend a very warm welcome to Dr. Deb Ghosh.
Let's see. Thank you for a very flattering introduction. I would like to thank the World Affairs Congress of Western Michigan, GRCC, Corewell Health for sponsoring and making this event possible. And special thanks goes to Dr. DeVivo for organizing this whole event and being an excellent host. Just before coming here, both back home, which is between Boston and Storrs, Connecticut, the temperature was in the spring. From Sunday here, there is cold and here colder, but looks like all the hospitality that I receive is keeping me warm and satiated. So I'm well functioning, and so I'm really feeling good. So I hope I can discuss my research and we have a good discussion today. So I'm not going to repeat the title here. It's been already mentioned. What I'm going to do is, this is my plan for today's discussion. I'm going to start with brief definitions of health disparity, then give some examples of health disparity among vulnerable communities from global regions to the local areas, and that's where geography plays a very important role, and try to encourage you to think more about the structures, the systems, and the laws that are the drivers of the health disparities, more beyond our personal risk factors or social determinants of health. This is my end wish. So at the end of today's discussion, I would like the audience or you discussing about
the role of systems, policies, and laws that shape health disparities. Think more on those structures and what could be done from your point of view, what could be done from the community health, and those questions. And lastly, think about the discipline of geography much more than a map location, country capitals, or maps. Maps are very important, and I'll be showing many maps, and that is why we took some more time in arranging all the AV system, because I wanted to make sure that the maps are displayed very well. But I would also like to have you think that the discipline of geography has an important role in understanding the mechanisms of health disparity and also come up with solutions to mitigate health disparity. So that's my end wish. So here is a definition from the Healthy People 2030. So Healthy People program is part of the US Department of Human and Health Services. Every decade, they come up with the guidelines of what are some of the important aspects and things that the United States should follow. So following their definition, the health disparity is a particular type of health difference that is linked with social, economic, and/or environmental disadvantage, and that adversely affects groups of people who have systematically experienced greater obstacles to health, well-being, and access to care. Here is another one from Center for Disease Control and Prevention: preventable differences in the burden, disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged, racial, ethnic, and other population groups and communities. Another term or phrase that you will hear along with health disparities and disparities in healthcare is health equity. Health equity refers to individuals achieving their highest level of health through the elimination of health disparities. So it is linked. So we will achieve health equity by eliminating health disparities. So we always I try to give a distinction between what is health disparities and then health equity, because you hear these terms used in the same discussion. So what are the drivers of health disparity? On the left, you see the term social determinants of health, conditions in which people are born, grow, live, work, and age are significant drivers of health risk and susceptibility within the healthcare system. So these factors are at the individual level, that is for people's level. So in research, in different health fields, health geography, public health, epidemiology, social work, law and community health, even in social work, when we engage in communities and do work with them, a lot of evidence have shown that social determinants of health are the main drivers of health disparities. A good, solid research has already been done, but we are not seeing any reducing of the gap of the health outcomes between racial groups or other minority groups. The gap is increasing, and COVID-19 pandemic just increased that gap. It opened the wound more widely. Just as a gaping wound, you can see that the more health disparities concern were opened up due to the COVID-19 pandemic. So the research communities are thinking, on the phrase on the right side here, structural determinants of health. Are we missing anything? Why are we not? So much research has been done, so many evidences have been provided, but why are we not seeing that gap being reduced? So that's why researchers are think more into the systemic laws and policies that might be working at the back, which are some of the root causes. So structural determinants of health are conditions produced and reproduced by laws, rules, and practices implemented at various levels of government and embedded in multi-dimensional social, economic, and cultural domains. right? So these are some of those laws that are happening behind or before our social determinants of health started to happen. So this is where most of the focus is right now. And structural determinants of health engages in theory, incorporates history, geography between group variations in health via multidisciplinary approaches. And this is why, this kind of audience where I have diverse people from diverse backgrounds and levels to hear discussions around this, because we need multidisciplinary lenses. It's true in academia too. None of these social health issues will be solved by a health geographer, by a public health. We all have to work together towards these issues. Let's see an example here. This is not my work directly, but I've been involved with this group and this group of researchers. And this is just an example where I'm going to draw out the differences between the social determinants of health and structural determinants of health. So you can see a web of causation of structural and social determinants of health on the circle here. Can you see my cursor? Yes. So increased maternal and infant mortality. So that's the health outcome here. These solid circles are the social determinants of health. Income, education, housing, access to care, individuals' access to care, individuals' education, individuals' income. And interestingly, you can see how education is linked to so many other circles here. Extremely important. However, you can see these square boxes, which are the structural determinants of health. These are the laws and policies starting from slavery, Jim Crow, 13th Amendment, redlining, and we'll talk about the redlining in my current research in the later half of the talk today. GI Bill, there are some other squares I can think of that are happening regarding women's health, all the issues right now and the controversies that are happening that could also affect here. You can see these structural determinants of health have dotted lines connected to this health outcome here. They may not be tangible, showing direct, but they are also playing quite a bit of important role surrounding the social determinants of health. Okay, I'm going to pause a little bit here and let you, for 1 or 2 seconds, see how these lines are connected. So even though they are dotted lines, the structural determinants of health, but they do play a very important role. So, with that, I'm going to go to my discipline area where we're going to go to some global to local study locations and see some health disparity examples. So, let's see if I can manage all. So here we are in Grand Rapids, right? From there, we will travel all the way around to a city called Kolkata in India, in eastern side, where I did one of my research. It was done around we started in 2019, and I'll talk about more, but a little bit about the place here, the geography here. This is one of the 4 mega cities in India, highly populated. This is where British started their East India Company too, many years, and no one can forget the impact of colonialism on India, and still we have the impact of very strong. And this is where I was born too. So this is the place me and my student did one of our study. I'm handling the AV very well. So far, so good. So here we will see some examples of health disparity among gender diverse communities. The study title is Shakti, studying healthcare access among Koti, transgender, and Hijra individuals. Shakti is it's a Sanskrit word meaning power. And you can see these terms or words, Koti, transgender, and Hijra individuals. These are names of different gender diverse communities in India. There are several, but these are the ones which are more dominant or in high numbers in the eastern side of the country. This would be another discussion of how the namings have happened. It's mainly based upon that we have so many languages in India. The languages are different, and also not only language, there are certain differences between each gender diverse community. They fall on a spectrum of non-binary identities. Interestingly, with the impact of the popularization of the Western LGBTQ movement, the transgender word has moved from here, from the Western world to the other parts of the world, and people from gender diverse communities have often described themselves as transgender because they are easily identified, they can easily communicate, and the NGO movements are also working towards the word transgender following the Western trend, and it is relatively easier to get funding. So there is a lot of other things going on. I just digressed from my topic. There's so much to say here, but I want to take one thing out from this title here is that there are several gender diverse communities in India, and I'm only focusing on 3 for this study. And this is in collaboration with my former PhD student, Shamoeta Banerjee, who is currently an assistant professor in the Point Park University in Pittsburgh. She's an amazing student. So this is the study area. We just saw it on Google Earth. In later half of 2019, we did surveys, intensive surveys, focus groups, interviews with almost 110 participants from gender diverse communities. Along with that, we visited India's first transgender clinic, which happened to be in this southern part of the city of Kolkata, which is more affluent, more liberal, more open, and that's where the first transgender clinic was started. And we also visited some community counseling groups to see how things are happening there. So we visited many places. Then we were fortunate to do at least this part of the study just before the world was shutting down because of the COVID pandemic. And we did our analysis sitting at home, going everything virtual, but we did our best trying to do all the analysis. Several analyses are yet to be done, but so far we have published 3 articles from this first phase of the Shakti study. On the top left, there is this article in Social Science and Medicine where we actually looked into the assessment of their mental health and physical health, going into more of the numbers of how the gap of the health disparity between gender diverse communities and cisgender. On the upper right here, we went to these structural determinants of health, looking into how some of the laws that are currently happened at that time in India played a role into what their physical and mental health status is. And very recently, we also published another article where we looked into healthcare access barriers. All these are linked. And I'm not going to go through all the study findings here, but go to another geographic visualization called story maps, right? Many of geographers here, either students or faculty, would know the story maps is a very intuitive way of showing our study findings out to the communities. It's very intuitive and looks cool also. Yeah. So we created this story map, and I'm going to go through not all of it, but few areas here. And at this point, I like to really thank the AV support system here. This website was not working. They made it happen. So, yes. Yeah. I waited for this opportune moment to thank you. So, when we decided to, yes, both of us were from that area, but just because we were born and raised that area, we did not choose Kolkata to be a study area. Many things were happening. As I said, first there was a transgender clinic there, and in Kolkata is one of the very liberal area, and all kinds of activism starts from that city. So, two legal reforms were happening in India at that time, which was very critical for the healthcare access and well-being of the gender diverse communities. One was the decriminalization of the Section 377 in 2018. This law was age-old law from the British colonialism, British law, which made criminalizes any consensual sexual conduct between adults of the same sex. So, which really prohibited any health issues that LGBTQ communities were facing. They were fearful of the system, fearful of the law, fearful of the policing, and therefore they did not seek health. So that got decriminalized, and there was a huge victory. And if you can see the timeline here, we jumped many decades, but you can see how so many years works, activism and social work needed. And then was this Transgender Persons Act of 2019. This included many clauses and laws that helped the healthcare access of the gender diverse communities in India, but it also had several restrictions. So it's one of the papers that I just had in the previous slide. We actually critically looked into the bill. What is good, what is not, what could be happen. There's no point being critical at the very beginning. Nothing will move forward if we are too critical of everything. But I'm just glad that there is an act for helping the transgender population here. It will never be perfect, and therefore there are amendments. And that's why we need more work like this to show these things are working, these are not working, and therefore we need to change the law. But if we go against the system very hard, there'll be pushbacks, and we know from all our experiences that doesn't go well. We just beat around the bush and we never forward with anything. There are some controversies here, but there are some good things as well. So this was the structural background in which we studied the health and well-being of this population of the people we talked to of 110. I'm going to just show some interesting findings. So there was one question, and we used a validated survey. That's all academic part, which we'll skip here. So one question was self-reported general health. What do you think about your health? And they are going to be self-reporting it. These are the approximate location of our study. As you know, I cannot show vulnerable population location directly on the map. So the approximate locations of the people who are red and black were not having good health. But what it looks like, most of them have good health. But when we dug deeper with other questions and we analyzed, we saw there was a big gap in their physical health and mental health. So what we saw that based upon our non-participant observations and informal discussions with the participants, we speculated that the community members were in denial. Even though I am from that area, I speak the language, I'm still an outsider. Then I have years of US thing with me. So they wanted to be nice to me. They wanted to show their best behavior, So they were not reporting their general health in the true way. And that came out when we looked into other questions in the survey, and we found out this big gap between their physical health and mental health. And this was one of their denial. And many of us use denial as a coping strategy with what is happening. So that was one very eye-opening thing for me that, they reported well, but when we saw their physical health composite score, which is a score from 0 to 100. 0 is worst or lower values are worst health, and if you go towards 100, you'll see better health. As from the data, low was as low as 26, high was 67, mean was 49, and anything below 50 was not acceptable in the good. So you can see here let me bring the legend up. These people from these areas had relatively better physical health, but mostly none. Same story with the mental health composite score, but mental health was even worse than the physical health. And physical health, they had to be strong because they were not accepted in the mainstream economic system. So they have to do more work, more labor, and all that hard work. As you can see from the legend here, mostly in the light colors, which means they had severe mental health issues. Their mean was around 42, standard deviation was 13. So these were some of the findings here. But one quote I like to read out from one of the participants, and this came up with several of our informal discussions. Quote, "In these 40 years of my life, I've given several interviews being a transgender. All health interviews only asked me about my sexual health. I am glad you asked about my physical and mental health as well." So some surveys, they all talked about their sexual health, but they were very happy that somebody else was talking about something else, that they do not have to explain their whole situation of their sexual health, that they have to ask all the time. This blue doesn't read out well here. Let me see. But some of the other findings, as I was talking about, mental health was worse than the physical health among this population. The young, low-income, young and old transgender were most vulnerable. And some of these findings resonated with the concern and appeal of the trans communities of Kolkata. So as we were finding these results, we also did some, at that time we could only do virtual. We did some virtual meet and greet to see, hey, this is our findings. What do you think? We did not want it to be that group that we go there with some dollars, do our research, and come out of the community. Community research is very hard. You need to build trust. This is where we are trying our best to build that trust. And these findings also contribute to the visions of the Sustainable Development Goals 3 and 5, which are also very global issues, whereby a society would be inclusive of all people, irrespective of their gender identity, and that everyone should have equal opportunities for improving their health and well-being. So this aligned with the SDG 3 and SDG 5 as well. Baby steps towards community-engaged solution. I will not be standing here and saying that I have all the solutions. This is not easy things to solve by one study, or we need more studies like this, more voices. So what are we doing in our next step? I'm not going to stop working with the gender diverse communities. We like to continue strengthening the activism of transgender community leaders and members by providing insights from the research. They might not have, they have a lot of insights, a lot of lived experiences, which we do not. We have the skill to condense all those and show as a results that might help in their voice when they go up and talk with the policymakers and the people who actually make changes, to show the evidences. So this was right before the pandemic. We did one in-person meet and this is my student back there in a few years. I think everybody looks different pre-pandemic and post-pandemic. I always feel like. So she said, "Tabs, you must have shown my old picture." But this is when we did a meet and greet, and she was showing a poster presentation, and the participants were very happy that they were seeing their data or their voices on that. So another takeaway from community engaged work, to always keep that dialogue open with the community members. So I'm going to end this story with another quote here, another viewpoint from a participant. Decriminalization of Section 377 was a historic judgment. Let's see if I can increase the font. Historic judgment. They can now identify themselves as a transgender and not get arrested for it. They can visit a doctor and mention about trans-specific healthcare needs, which are very important to hear, without being arrested. However, more needs to be done for reducing stigma and increasing recognition and equality. So this is where I'm going to stop or end this story here, allowing you to ponder what I started with. Think more beyond that they were transgender, they might have specific health needs. Yes, they do. Like many of our of individuals, we need some specific health care. They also need. It's nothing big deal. But the important is this impact of laws. This law was lifted and decriminalized, and that will help more. If the law was there, more research showing more disparities wouldn't go anywhere. We have to target the laws which were the barriers. Okay, so from there, now that I'm on the website here, I'm going to use some geography again here. And we will now go to Eastern Africa. Right? This is Kampala, capital city of Uganda, where I did my sabbatical research with another former student, Diane Benbella, who is a Ugandan herself, and she's currently employed by University of Connecticut, working in the Research Foundation department, where he brings people together to do more interdisciplinary research. So this is Kampala, and here is another geographic perspective on health disparity. So HIV is an issue in Africa, it's not new, but what we found here is health disparity along transportation route, along the truck route in Uganda. So Uganda has one of the highest HIV prevalence rates in sub-Saharan Africa, and 6.5% of the population is living with HIV, which falls under UNAIDS definition of generalized epidemic. However, this is the Northern Transportation Corridor, or NTC. So this is the truck route. And there were districts along the truck route which had high HIV rates than the national average. Very spatial story here, geographic. So this is, we know all the risk factors of HIV in general in Africa, and some would be specific in different parts of Africa and Uganda. But what is happening here in this transportation corridor? So driven by the unorthodox lifestyle of the truckers, our HIV high-risk group, these districts have among the highest prevalence. So the truck drivers had high-risk behavior in sexual activities. They stopped into these districts along their route, and that was a reason to spread the HIV infection. These districts also happen to be rural districts with less awareness, less counseling, less access to healthcare, less organized healthcare as well, and districts with nomadic tribal population. So it was difficult because of their tribal nomadic behavior. They probably couldn't be all the time in the same place to get the full regimen of HIV treatment. So these were some of the issues very specific to that region that was happening. And that is geography. That is the geographic perspective of what is happening along this transportation route. Here is a systemic HIV policy called 90-90-90 treatment target. The UNAIDS and the Ugandan government jointly launched the 90-90 target as treatment as prevention strategy they call TASP. What they do is they tried to aim, and this worked well. This really worked well at all districts in the whole country, that they want to achieve 90% of testing of each district and to find out the status of HIV negative or positive. If they're positive, move 90% from this bin to on the HIV treatment. And then from that 90% to this final step of viral suppression. Viral load, we must have heard all these words from our COVID-19 pandemic experience, is the virulence of or the capacity of the virus in our bloodstream. So they try to reduce it under HIV, there is no cure yet. So you reduce it as much as possible so that it's not transmissible. So that's the final treatment outcome of any HIV treatment, viral suppression, and they want to reduce it as much as possible. So that's called 90-90-90. When we were trying to assess these programs along the districts of the NTC, the policy was still at 90-90. Now it has gone to 95-95-95. So let's see our results to see where are these districts along this NTC in terms of this 90-90-90. So here is a map of the prevalence of HIV. So all the districts which are colored dark brown here are above the average, which is around 6.5 to 7. And then the light yellow color, which are under the national average. So now on the left, you will see how, the districts are linked to care, right? So they are linked to some HIV care, and you can see very few are that darkest brown color here. And most of them are from 70 to 90, and then you have really falling below. Like if I have to use the grading system, it will be C grade, 50 to 70%. And you can see the receipt of care is still quite dismal. So if you break down by 90-90-90, although maybe as a whole country, the Uganda is reaching there, but when you break down by district, it's not there. And this is a classic scale understanding in geography. You look at the whole country, good to go, but when you dig into these areas, you see some disparities by districts. And mainly these districts are the rural district. So what are some of the possible health interventions in terms of structural things that we showed in our study? First of all, have targeted health interventions. This 90-90-90 or 95-95-95 are working really well, but we need to pay more attention to some stigmatized population like the truck drivers. More counseling, more testing needs to be done. Maybe have testing. There is a lot of UNAIDS money. They're going to be testing locations along the route, so there's no limitation there. One thing that we identified is the lack of data. It was so hard to get that 90-90 data by each district. We had to do many calculations, go from one health department of each district to another, and it reminded me of my experience back in India. And it was those health departments looks old, all paper copies stacked, all dusted, and I felt like, wow. Then I said, oh, this is all British colonized countries. The health departments are working in the same way. I said, oh gosh, do I have to put that hat on and be that resilient and that just be there, stand there and get the data. I did to my expect, but it was frustrating to get all the data. The districts falling behind the treatment targets were among the poorer districts in Uganda and have very few health facilities, mostly government-owned. The districts which were doing well and achieved that 90-90 target had very focused health departments. Those are called TASOs, the health aids the AIDS support organizations, the TASO, and Kampala has a good one. There's a few other districts. They also have good ones, but rural district did not have those situations. Few districts that have critically low rates of viral suppression are home to nomadic tribe. That's their culture. It will take much longer to change a person's culture, and should not be our way to address health issues or health interventions. Rather, maybe we should be thinking of tailored interventions such as mobile health facilities that will not be fixed to one location, and that might help in flexible locations to refill their antiretroviral drugs and all other drugs that they need to keep on the regimen and go from this linked to care, receiving their care, and finally reaching that viral suppression outcome, which is the desired one to keep down the HIV transmission. Okay, so I'm going to take a pause here because we will now come to United States, where I will talk about my current research. I will not go to Google Earth because we know where we are in terms of the US. So, with all this in background and still going on, my current research, which is keeping me very busy right now, is trying to understand the associations and causality between structural determinants of health disparity in the US. And I said in the first two slides, the research communities are beginning to acknowledge racism and not race solely as a variable or as a social determinant of health, rather as a structural basis. A key question, however, remains is how we measure this. And this is where, in the two grants that I have right now, we are proposing two products to address structural racism and discrimination, SRD. One is the true index here, is the multidimensional composite index of SRD. We have just started the work. We're going to build this index at the county level for the entire country, and it will be multidimensional. The dimensions will range from redlining and racial segregation, one of the squares I showed you in the first 2-3 slides, then incarceration and violence, medical resources unequal, and then concentrated poverty. So several of variables and data will go into this, and we're going to build this index. And we were hoping to have a website which will be accessible to not only researchers but community health workers, stakeholders as policymakers. This is just an example. I hope to have a better website when I'm there, and this is just kind of a framework that we are putting our thoughts together. We'll have all these dimensions that I just talked about will be on the top, and things like hopefully I'll be able to share that in a year or year and a half. That's my time goal for this. I think I'm running a little late, so I'm going to go to the main things here. Okay, so as I said, we'll talk about the redlining. So this is one of the current questions that me and some of my current PhD students are working on. Is the present-day neighborhood health disparity in the US associated with historic redlining? So the present day is the lack of healthcare access, right? And I'll show you the data for that. And the historical redlining is coming from this homeowners loan corporation redlining program. It is famously called now HOLC maps, HOLC, and I'm going to show you more information on that, and how these linkages are happening to creating racial segregation, creating income inequality, and that is all leading to lack of access to healthcare. Now, here is the source of that historic data here. Okay, let's go here. So Mapping Inequality is a project done by University of Richmond's faculty and students there. They did an amazing job of going back to the paper maps from the 90s, 30s, and 40s, and they digitized it and make that all maps. So what is this redlining? In 1930s, the federal government created of the United States created redlining maps for almost every major American city. It divided the neighborhoods into 4 categories. A, they call it A, B, C, D. A is where you have desirable people living. They will not default on loans. They will pay back their mortgage loans all the time. The risk is much lower. Then you have little bit less desiring, then declining, then really hazardous. They really use the word hazardous. So let's see here what it means. And this group has done this data digitized and mapped all of here. Let's go to Grand Rapids. You can see these 4 categories here. Best, still desirable, and you can see here. You would know the geography of Grand Rapids much more than me here. 5% were best, and this is from 1930s and 1940s. Less, still desirable, definitely declining, and hazardous, A, B, C, D. And this was coming from the bank's point of view, the bank who gives a loan, that people will not default from these areas. And you can explore this website, Mapping Inequality, and you will see how the terms were used back there of how to describe. And some are not good languages used there in things like that. So we collected the data from this group, and then we continued with our research, as I will do with my talk here. So we took the data of the redlining from the Mapping Inequality Research Group. Then we analyzed the persistent poverty. Persistent poverty is a measure by an area, not chronic poverty that you will hear by the people. Like people who are facing poverty for a long time, chronically. But persistent poverty are areas in the United States, here in the county level, which has faced 20% of people consistently below poverty level for 4 decades. So this is those counties. So that shows how I'm linking from the history to the current. And then we have the current day, and I've used the US 2020 data to show relationship between racial segregation and the poverty, those two. So the pink counties here are where we have high concentration of one race. So here we have high race of Black Americans, and here we have concentration, highly concentrated of white Americans. But both these areas are showing a positive relationship between concentration of race and low income. So here we have, I'm not saying that only low income is happening only one race, but there is a situation here. But here is also the areas where we have persistent poverty over 44 decades. So you can see how these areas are aligning, overlapping with each other. And then you have this low access to healthcare, which is a measure used by the Health Resource Service area. They use several variables to calculate that. And darker areas are areas where you have very low access. This is also that same areas we are seeing these phenomena. So we took all this data, which you just showed in this animation, and we found that 16 counties, which are the yellow counties here, in 4 states of Louisiana, Mississippi, Alabama, and Virginia, where you have persistent poverty going over for 4 decades. Then you have a positive relation between concentrated and segregation, and concentration of low income, and you have low access to healthcare. And interestingly, you can see how close are those redlined areas. Now, you would think, well, this is still far away. But remember, those red areas were drawn in 1930s and 1940s. Do you think the disinvestment and amenities which didn't happen because of the disinvestment, it will be only in those areas? No, it will have a spatial effect. It will have a spillover effect around the areas too. And you can see in Mississippi somewhere right there, those redlined areas that happened in 1930s and 40s are still playing quite a dominant role in these 16 counties. There are other counties as well which were very close to each other, but maybe revitalization are happening, the segregation is breaking down, but these areas consistently showed segregation and poverty and proximity to redlined areas. Redlining has come into highlights in several media and news reports, and CNN is one of them. During the pandemic, I was interviewed by the CNN Business, where they picked up one of my study and asked about, and they were writing an article on how the rise of supermarkets left out Black America. And they made the connection with the redlining areas. Another group studied the redlined U.S. homes face higher flood risks from climate change. So you can see the quote here, the discrimination that happened in the past may seem like it happened a long time ago, but it compounds. Redfin chief economist Daryl Fairweather told CNN Business, it's not like the historical practices that were discriminatory diminished in effect. It seems like they're actually increased in effect. Here is another study, Black people in redlined neighborhoods face higher risk of heart failure. Right, so you can see this study also draw connections to the redlined areas. So with that, I'm going to draw close to my discussion here, and I hope I achieved my end wish that you will be thinking that yes, social determinants of health, of how we, each of us are built by our age, gender, race, and whatnot, but there are structural determinants of health which are also playing quite an important role here. And I also like to give a little bit more focus on the geographic perspective here, because I hope I made that connections that looking from a geographic perspective also gives more emphasis or more importance to understanding the structures here. Geography is a science of place and environment. Each place on Earth is distinguished by unique, but what makes geography discipline strong is what makes each place unique, but we understand the connections and interactions. And, I was talking to Cheryl here before that I consider myself very privileged. Growing up in the family what I belong to, I did whatever I wanted to do, and I'm blessed for that. But I did see the strong caste system in India, which has much history than the racism in the United States, and that has divided the society into very hierarchical groups, people, partisan politicians from different governments of India have used the caste system in their own way, basically, to win votes and everything. So when I started to study racism and impact and structural racism in the United States, I drew parallel to the caste system to here, and that is where being a geographer is very helpful. And it was one of my aha moment when, and I'm a big fan of Stephen Colbert. So when Isabel Wilkerson, one of the Pulitzer Prize winning author, was invited to his talk show, and she was making this connection between the caste system of India and the racism in the United States. In her words, she says, racism is an insufficient term for the systemic oppression of Black people in America. Instead, she prefers to refer to America as having a caste system. So if we don't understand the structure and we only allude to our own attitude towards race, we will never understand the impact of the structures. And that's why relating this to the caste system was very important. And I said, there's somebody else is also thinking like this. And it was a very exciting moment for me. And I'm going to end with this. Thank you. And as if you have gotten email from Dr. DeVivo, geography lives and geography matters. So I will end with that.
Thank you so much. Thank you, Dr. Ghosh.
Sorry, I took a whole long time.
Very interesting. It's time for you to ask some questions. If you're in the hot, just raise your hand and we will get the microphone to you. If you're online, you can use the YouTube chat box, or you can text. You can do that if you're here or online, 616-308-6560. and we will try to get to your question. So who's got a question for our intrepid geographer to start us off with? Microphone's coming around.
Comment on access to health care with, from a geographical perspective, those nations that have so-called socialized medicine and the access versus those nations that traditionally have had a private healthcare system or a quasi-private healthcare system, and how that interacts with the comments you made earlier.
That's an excellent question, and I teach one of that topic in my upper division undergraduate class, where I compare the healthcare system of different countries and how that might affect the healthcare among different populations. Yes, one of those universal healthcare and the socialist model, the healthcare, can you hear me? Yes. Healthcare model is better, works better, because the access is better because you don't have to pay for all that. So when I say, let me trace back. So access is multidimensional. So you have this physical distance where you have to drive and whatnot. So that is still an issue, any rural area, different parts of the world to urban areas. So that is there. But access also has other dimensions of affordability. So a system in the countries where you have universal health care, that cost burden is significantly reduced. Then there is another dimension, and if you, Thomas, PNT, Penchasky and Thomas, have used these 5 dimensions of access: availability, affordability, accessibility, acceptability, accommodation. I remembered. So yes, those 5. So you can Google the study, Penchasky and Thomas. So if you think of these different dimensions of access, you will see different. One country is doing good in one country is not doing good in the others. Unfortunately, the United States does bad in many of these A's here. Availability is excellent in the United States. Who can afford? There is no doubt the quality of care in the United States, it's a top one. But very few people can afford that and hence can access that. However, in UK, which has got the National Health Service, availability has a spectrum. So you'll have the GP system, the general practitioner, it's very good access. It's all covered, nothing. But if you have to do some specialized services, that might take a long time. There is a wait time. In India, there is a combination of public and private. So some parts are covered for all, but some families or people who can afford can also go to private in addition to the public. So that model is working for certain middle class and above. But middle class and below, they are only going to this government facilities. And that is actually what I saw in Uganda as well. So government facilities do not have good facilities. And if you can go to the private ones, those are better. So you had a succinct question. I had a long answer. So I hope I answered your, yeah. Mm-hmm.
Dr. Ghosh, do you see, is the medical community open to this geographical analysis that you're doing? Are you seeing in your career, are you seeing more of that, more acceptance of your field and laying that on some of the healthcare issues to the benefit of all?
Yes, definitely. So, and I'll speak from some of the critical points, funding, right? If I don't have funding, we won't be able to do the research. So NIH, National Institute of Health, is now open to more neighborhood health work. So, and I was interviewed there that what kind of reviewers you would think would be helpful to judge this kind of proposals. Because, so that would be a critical point to say that things are opening up and they're open to do more neighborhood health work because they're putting in money, and money talks. So that would be my one direct answer for that.
Hi. When you were talking about Uganda, you brought up how it was the nomadic groups that seem to have the least access or the least success with treatment programs. Does the fact that nomadic groups might be more likely to move away from the transportation corridors in urban centers play a significant role in that?
That would actually be more detrimental, because that is why if the intervention needs to work, it needs to work at their place or maybe not far away, because of their travel behavior, they would be moving with the infection. So that would be detrimental. It will not improve their access or the risk of transmission. And actually, we need to have intervention with counseling and treatment before they travel far for urban areas. That will actually increase more numbers of HIV.
As I'm sure you're aware, the type of research you're doing has some risks of finding what you're looking for. You know, you make a hypothesis, and then you go out and you find evidence, and look, I was right, you know.
Or wrong.
Or
wrong.
Or wrong.
Yes.
So what do you do, for lack of a better term, control group, to kind of check yourself to make sure that you're not just finding what you are looking for, but to double check? I'm not saying that really well, but I think you can.
I was hoping when I will get a tough academic question, and you have it. Yes, this is a limitation if I am speaking with very clinical-minded audience here, because they will want the control group. And I'm not saying that's wrong. You want to see a control group. That's why I would like to start first showing the results as an associations and not jump to causality. If I have to do causality, then I have to show the control group and then show other steps. It is difficult to show the control groups here. I have to then have, so the way we control is we see the same measures among, let's say in my current research, Black Americans, but I will have similar data and measures in the white Americans and see the differences. That is where the control group will come. But it still has some limitations to draw causality. So I do not have a right answer, but that is a tricky question, and I get that from all the reviewers all the time. Yes.
Conducted your research in West Bengal, which is ruled by a regional party, which is at loggerheads with the ruling party in New Delhi. How challenging was it for you to get approvals from the government departments, because there is a lot of mistrust in New Delhi about NGOs? So what was your experience in that context?
I'm glad you brought that up. It was very challenging. I didn't even have to go into the politics, just because, sometimes we say that if I look like the people I'm working with, if I know the language, it would be easy. No, for me, this was a negative characteristics, because they were thinking that I was born there, then I left. And then I'm coming back to study them, and I will leave again and publish papers and never come back. So this was a big challenge, and I had to go several times to build that trust. So even before the politics come, just in research, it's called positionality. When we do, like, how do I positioning myself when I collect data? And my similarity, me being from that region, was not very helpful. So, and when I wanted to do HIV study work, I was shut down. I did not get any approval to do HIV work, because even if I have a grant of $1,000, I have to go 8 months of approval, even harder than the IRB approvals here. So it's challenging work in India, and I will not, I will not be nice, or I will not lower down. It is challenging. But we collected data, behavioral health data. So in terms of approval from the West Bengal government was easier. And since it was not HIV, I didn't have to go anywhere outside the state and go to the federal, not the federal, the national one, so the Delhi government. So, but even then, I had one picture on my story map where we went out to socialize with the study participants to make them feel included. And I knew from my training of doing qualitative work that I cannot dress like this. I had to wear my Indian clothes to be more inclusive and that's why I love wearing saris. Yes, so I had a picture of me there wearing. So yes, so these things were very important. So even before going to politics, me being myself was a barrier first that I had to cross.
With your knowledge and background, if you could tell us who you think is the best country or countries that has done the best job of trying to create an equal health result and overcome the caste and geographical factors that otherwise would distinguish it. Who's done the best job of fighting or conquering those impediments?
Another tough question. I have to think about this because it's not definitely, some of the South Asian countries are not doing well. Caste, race, none. When we have these intersections, it's struggling. The countries that I can think of has more or less good health throughout are Scandinavian countries, maybe Sweden. Then Sweden had controversial COVID-19 policies, as many of you remember. So that's a question I will think. So the countries which have less diversity are not doing well, which means we have to do more work. Yes. Hi.
I have a question. So first of all, thank you for your presentation. One of the slides that really stood out to me is the map showing the concentration of the socially constructed races of Black and white in the two areas that you showed, and how the concentration showed sort of health outcomes that were less than ideal. One of the things that I feel is very important in the US when we think historically is the Great Migration between the 1930s and the 1970s, where the Black population had a significant migration from the South to the North and went from still segregated in the South and thinking about Jim Crow and those situations to the North where there was still the segregation, maybe some different job opportunities, but still that concentration. So my question is, in your research, have you looked at the Great Migration at all? And then also, are there other countries that have had similar experiences where there may be similar outcomes when it relates to health?
So first question about the migration, no, I haven't looked into that. So that would be one way, creating another measure of longitudinal racial segregation to see, like the way we have a variable like persistent poverty, whether how the concentrations have changed over the years in terms of the high concentration of African American population. So I haven't, but that's a good idea. In terms of your second question, other countries, nope. So the caste system is still a negative factor for health in India, and nowadays with caste, race, gender, they're all intersections happening. So that would create more issues. So we don't I see similar problems where you have this overlapping of social determinants of health and in the background structure, which will make us think more into these intersections of gender, race, caste. And to throw another item here in the mix is religion. There's another factor that is creating another source of the disparity in health. One thing I forgot to mention before I take another question, because I think that is important, is some of you, I want you to think, because you know more of this Grand Rapids area than me, we are in this water boil alert. I wonder how would those areas would map out to this hazardous or definitely declining. So maybe if you, Mapping Inequality is the website where you will have the dynamic data. Yeah, this is better, it's still open here. So yeah, where is East Grand Rapids or the central parts? So maybe I don't know. I'm not saying anything, but something to consider, whether whatever happened, the pipes are broke, or I'm not sure what exactly happened. Are these yellow areas or hazardous areas and whatnot, to see how infrastructure is still old in those areas and nobody took care of it. Definitely all the Flint and Detroit issue water would be linked to this redlining. Yeah, sorry.
So I'm curious how medical tourism plays into this, specifically in regards to how money can go farther in some places if you're able to travel there.
I'm not an expert in the medical tourism, but it has been very popular, and the trend has been from Western countries to other countries, especially to the Asia. Yes, it has been a trend, but it is also among the privileged. So I don't think that it will it is one of the solutions for health disparity. It might open up for few who can afford to do that, but you still need to, it's for selected groups.
My question is sort of similar to the causation correlation issue. How do you differentiate between the effects on health outcomes that are related to geographical effects versus just sort of coincidentally corresponding to or being more from stigma, so is it access to the system because of geography, or is it once people are in the system, the stigma that they face even within the system, even if they have good access?
Great question, and I will go to that slide where we had all those lines, right? So it is not an easy thing to study. A counter question to you would be, do you really want to see what each of them does separately, or you want to see them together? What are some of the combined drivers of health disparity? It might be difficult to tease out. I'm pretty sure if my biostatistician in my field will have numbers for all those lines, but it is important to see them interrelated with each other. That would be my answer.
Let's thank Dr. Ghosh for a very fascinating evening.
Thank you.